Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to the last session in the second competition of iTeach. First of all, I would like to thank all the panelists for their time to be with us. And of course, many thanks to the presenters who are keen to present their knowledge and to be evaluated by the panelists as well. And of course, I want to thank Dr. Tariq for assisting in organizing all of this. So let us start with the first presenter, Dr. Khalid. Dr. Youssef will be with you.
Assalamu alaikum. First of all, I would like to thank iTeach board for their efforts. Can ultra-wide field imaging be life-saving? Let's start with some history. The first fundus camera was developed by Carl Zeiss. It could detect about 20 degrees of the retina. Then more wide field imaging retinal cameras could detect up to 96 degrees. When you capture wide field imaging, you capture from the vascular arcades up to the vortex veins ampullae. When you capture ultra-wide field imaging, you capture from the vortex veins ampullae up to pars plana, up to 220 degrees. As you can see here, the inner circle implies the old traditional retinal cameras. The outer one implies the wide field retinal imaging. Outside this outer circle is the ultra wide field imaging up to 200 degrees of the retina. Regarding diabetics, early treatment diabetic retinopathy study has their own standard 7 fields, but it could only detect up to 30% of the entire retina. Diabetic retinopathy studies showed that most of diabetic retinopathy pathology is in the periphery outside these 7 fields. As we can see here, the new vessels could be detected only in ultra-wide field. The PDR is appearing here outside the standard 7 fields. Studies showed that ultra-wide field fluorescein can detect 4 times more number fusion, 4 times more BRB marks, and about 2 times new vascularization than the 7 standard fields. As you can see here, the ultra-wide field could detect more BRB marks. The most associated term with ultra-wide field is predominantly peripheral lesions, BBL. What is this? Predominantly means most of them. Peripheral means outside the 7 standard fields. Lesions, any diabetic retinopathy lesions. As you can see here, most of diabetic retinopathy lesions are outside the classic 7 standard fields. Same for here. ETDRS had to cope with updates. In protocol AA, Marcus et al. Described that ultra-wide field color photography is not associated with diabetic retinopathy worsening. BBL in color is not associated with diabetic retinopathy worsening, while in ultra-wide field fluorescein, they are associated with diabetic retinopathy worsening over 4 years. In this study, they found that most of BBLs is in the temporal quadrant of the retina, especially in this superior temporal quadrant, extended field 4, and the least BBL is in the opposite, inferior nasal, extended field 7. Same here, 4 and 7. Did I use life-saving to get you here? Yes. Is ultra-wide field imaging life-saving? Of course, yes. In this study, they found that the more grade of diabetic retinopathy, the more BBL. Surprisingly, with an exception, moderate MBDR had more BBL than severe MBDR. Okay. They also found in diabetic patients with BBL, 62% of them had coronary artery disease. In this study, they found that BBL are associated with 4-fold increase of diabetic retinopathy progression. Also, they used automatic method to detect hemorrhage and microaneurysm. They found that they are associated with renal disease and anemia. Okay, we all know that diabetic retinopathy are associated with renal disease. But surprisingly, they found that the association of BBL with renal disease and anemia is independent of HbA1c and independent of the diabetic retinopathy severity. Takayasu arteritis is a large vessel vasculitis, which can affect aorta. It can cause aortitis, so it's life-threatening. In this study, they found that ultra-wide-field fluorescein can detect about 95% of microaneurysms, in opposite to the normal clinical fundus examination, which can detect up to 19% of microaneurysms. They found that most of microaneurysms are in the periphery, so they found that Takayasu retinopathy is extremely underdiagnosed. They found that the more microaneurysms, the less central retinal artery mean blood flow velocity. Retinal imaging has always been systemically important in diabetics. In 2008, this study described that diabetic retinopathy is associated with incident heart failure. And in 2012, they described diabetic retinopathy as a predictor of coronary artery disease. More sophisticated studies found that diabetic retinopathy can be an independent predictor of subclinical cardiovascular disease. More surprisingly, they found that diabetic retinopathy can
Dr.
predict
Khalid, Dr.
angiographic. Yes,
Dr. Khalid, we can hear echo. Maybe you have
maybe another panelist is using speaker, but not from me.
okay. So yeah, go on, please. Thank you.
Now it's okay. Now it's okay. So a more sophisticated study
Yeah, now it's fine.
described diabetic retinopathy as a predictor of angiographic coronary atherosclerosis. My take-home message: although ultra-wide field imaging is most famous for early detection and accurate grading of diabetic retinopathy, it can be very important for the whole patient we are treating. These are my sources, and thank you.
Yeah, fantastic. Thank you very much for being on time. Okay, or even before time. Dr. Youssef, please.
Yes, thank you, Dr. Khaled, for the really nice presentation. I really loved it because the way you presented is really attractive, and you grabbed my attention all through the presentation. I really just have a couple of questions. Ultra-wide field, I think, is the way to go forward with retinal imaging. It's going to be available um, with time. But what do you think are the limitations of ultra-wide field imaging?
I think the size of the image, the macular area always appear smaller than real, and in opposite, the peripheral field are larger than real.
Do you think there's anything with the colors?
Yes, of course, the pseudo color is the same with Heidelberg, but I think its benefits are much more than its harms.
Okay, so you think you would get ultra-wide field for Oreo patients in the future if you have it?
Especially high myopes, you can detect more tears, much more tears. Diabetics, of course, and like I said, Takayasu, more systemic disease, Takayasu arteritis, uveitis, it will be much more helpful.
Okay, so I just want to make sure all the audience and all the people listening for the recording, both Protocol AA did not find a significant difference in predominant peripheral lesions in association with the progression of diabetic retinopathy. So it would not affect our usual everyday practice, but fluorescein angiography there may be a relation. So it's still in the beginning, it's still under investigation, I think.
Yes, please, doctor. Ultra-wide field color has no association, but ultra-wide field fluorescein is associated.
Fluorescein is significantly associated, but they're still under further investigation. So, yeah, thank you.
Thank you.
So thank you very much, Dr. Youssef, and for Dr. Khalid. Now, I'd like to invite the second speaker, Dr. Mahmoud Rifai, to start presenting.
Hi, Doctor. Inshallah. Can you see it?
Yes, go on, please.
Okay. Assalamu alaikum warahmatullah. Good night, everyone. I am Dr. Mohammed Rifai, ophthalmology resident in Yemen. I will give a lecture about updated ICO guideline for diabetic eye care. But first of all, I want to thank Singab Academy, represented by Dr. Mazen Singab and also Dr. Tariq Duais for giving me this chance. This is ICO guideline for diabetic eye care. In the first, I will talk about international classification of diabetic retinopathy. We have non-proliferative diabetic retinopathy and proliferative. Non-proliferative, no new vascularization seen. Like this picture, here cotton wool spot, and here hard exudate, and here blood hemorrhage, but not new vascularization. This is non-proliferative diabetic retinopathy. But in this picture, this is a venous feeding, and here there is new fizzles elsewhere. This is proliferative diabetic retinopathy. About diabetic macular edema, currently the diabetic macular edema divided in 3 divisions: no diabetic macular edema, or non-central involved diabetic macular edema, and central involved diabetic macular edema. In this picture, here hard exudate around the macula, but does not involve the central zone of the macula. This is moderate or non-central involved diabetic macular edema. But in the previous picture, this is hard exudate on the macula involved the central zone of the macula. About screening for diabetic retinopathy, in the first time, I will take history about duration of diabetic mellitus, about glycemic control, any medication, and antihypertensive drugs, systemic disease. Then I will physical examination about visual acuity and measurement of intraocular pressure, then gonioscopy when indicated, then fundus examination. If the visual acuity better than 6/12, routine re-examination only. If the visual acuity 6/12 or worse, this is non-urgent refer for refraction and assessment. But about fundus photography, diabetic retinopathy, if no diabetic retinopathy, also routine re-examination. If mild or moderate non-proliferative, also non-urgent refer or for refraction. But in severe non-proliferative or diabetic macular edema or proliferative diabetic retinopathy, urgent refer to ophthalmologist. This is initial patient assessment, history and examination, and fundus. Here follow-up, the same, except the OCT is the most sensitive method to identify the macular diabetic macular edema. How to treatment of diabetic retinopathy? We have 2 divisions: high resource setting and low intermediate resource setting. High resource setting, the first time optimized medical treatment to control glycemic control. No diabetic or mild or moderate non-proliferative follow-up just. In severe non-proliferative diabetic retinopathy, closely follow up to progressive to proliferative diabetic retinopathy. But in proliferative diabetic retinopathy treated with pan-retinal photocoagulation, this is high resource setting. But low intermediate resource setting generally is the same, except in severe non-proliferative diabetic retinopathy treated as proliferative diabetic retinopathy with pan-retinal photocoagulation, because the closely follow-up in low intermediate resource setting is not possible. Here, pan-retinal photocoagulation laser scar. in peripheral retina. About macular edema treated, if the macular was non-central involved, just observe or focal laser if leaky of microaneurysm. The central involvement diabetic macular edema, if the visual acuity better than 6 miles, might be follow-up or laser or injection anti-vitreal, anti-vascular endothelial growth factor therapy. But in central involved diabetic macular edema with visual acuity 6 miles or worse, treated with anti-vascular endothelial growth factor therapy. This is high resource. What about low intermediate? The same, except here anti-vascular endothelial growth factor therapy is not available or expensive or cannot one monthly follow-up in low intermediate treated with focal laser photocoagulation. Also treated with steroid like triamcinolone might be recommended in pseudophakic eye. This is a follow-up monthly about vascular endothelial growth factor injection. This is cover of ICR guideline for diabetic retinopathy. And thank you.
Thank you very much, Dr. Mahmoud. And I find myself the one who should discuss with you. It's a surprise for me because I am not retina. Anyhow, I have two questions. What is the cause of the cotton wool spots? What is the histopathology of the cotton wool spots?
Ischemia
Yeah, ischemia is
of
the
nerve
cause.
fiber layer.
Yes, it is the cause. But what happens if there is ischemia? Why we see the cotton wool spots? From where it come? Okay, this is because of axoplasmic transport. There is like a problem. There will be in the axoplasmic transport in the nerves, and therefore there will be mitochondrial problem and the accumulation of these spots. Okay, just to keep it in mind. Now, can we see a patient who has diabetic macular edema, but the vision is still 20/20?
Yes. If non-involved, the central.
How about involved? If it is involved and very mild, can the vision be 20/20?
Maybe.
Okay,
So
great.
we need closely follow.
All right. Okay, that's it. Thank you very much. The presentation was perfect, like all others, of course. So now I will invite Dr. Khalid Badakhoun to present, and
Badakhoun.
Badakhoun, okay, only one. Dr. Youssef. Dr. Youssef, before we start, how about my question? Can we see 20/20 vision while the macula is involved?
Yes, yes. If it's very mild edema in the center involved area, sometimes you can get 20/20 vision, and the patient can see 20/20 vision. Yes.
Perfect. So do you think that doing OCT macula for a patient with diabetes should be a routine in the follow-up visits, even the patient is 20/20 and the retina looks clear and clean? Is it of the protocol, one of the protocols to do the OCT?
No, I don't think it's routine. If you're seeing heart exudates around the fovea, that's another thing. Or if the patient has drop of vision and you want to check for edema, that's another indication. But for a routine case with 20/20 vision, I wouldn't do routine OCT for the patient.
Okay. But is it because of guidelines or because you feel no need to cost the patient money, for example? You don't want to make them pay money more.
Well, it's both because the guidelines especially for lower to middle resource settings like ours, they tell you if you have drop of vision, if you see center involving exudates, you go for OCT. And also because of the resources, I don't want to cost the patient more. But it's important to just consider that fluorescein angiography, I tend, if it's the first visit of the patient, and I start to see hemorrhages, even if it's not PDR, I do fluorescein angiography because you might be surprised, especially with Dr. Khalid's presentation as he presented. You might get NVEs and they might not be visible, especially in myopic funduses. It might be difficult to detect. So fluorescein, I'm tend to be more to go for fluorescein because it's vision threatening the MVEs. But edema, I can't tolerate diabetic macular edema, even if you get small edema and you missed it and the patient's 20/20 and you find it later, it can be well tolerated and reversible.
Yeah, very good. How about OCT angio? Can we use it instead of the fluorescein angiography for the NVE?
I'm sorry?
How about the OCT angio?
Oh, the OCT angio is definitely not routine for any of the diabetic patients. The main use is for neovascularization detection in AMD, for example. For diabetics, it might, in very narrow cases, replace the fluorescein if you have suspected NVE versus IRMA versus hemorrhage in the posterior pole, but it's very limited number of cases. It's not routine at all.
Yeah, thank you very much, Dr. Youssef. Okay,
Thank you.
Dr. Khalid.
Yeah, thank you. Did you hear me and did you see my screen well?
Yes, and of course, you are lucky because Professor Ibrahim Al-Adawi will be with you.
Okay. Hello, everyone. I'm Khalid Badokhan, second year ophthalmology resident.
No, not Ibrahim
Sorry.
Al-Adawi, Dr. Yusuf with you.
So you are lucky as well because Dr. Yusuf is with you.
Doctoral specialist.
Okay, I'm Khalid Badokhan, second year ophthalmology resident from Yemen. And this is my case presentation about central retinal artery occlusion with cilio-retinal artery sparing under supervision of Dr. Abdullah Al-Baham. Those are outlines that I'm going to discuss with you in my presentation. Okay, our case is 44 male patient presented to our hospital with 1-day history of tunnel vision in the right eye. He described the vision as curtain hanging with no peripheral vision. So I'm thinking about many differential diagnoses like retinal detachment, optic neuritis, central or branch retinal artery or vein occlusion, vitreous hemorrhage, and non-arteritic ischemic optic neuropathy. So from history, patient denied fatigue, jaw claudication, scalp tenderness, headache or fever in the past 3 days. Also, he denied eye pain, flashes, floaters, diplopia, or recent trauma at the time of presentation. Also, no significant was detected on review of systems, and no significant past medical history, social and family history. So sad we not reached any point from history. Now, from the examination, the vision acuity was 6/18 in right eye and 6/6 in left eye. IOP was 16, 18 respectively. Slit lamp examination showed normal anterior segment. This is the fundus examination for this patient, and this is fundus picture for right eye showed superior and inferior macular ischemia with preservation of the fovea due to cilio-retinal artery perfusion, and normal flat fundus in the left eye with normal optic disc and macula. So we sent this patient to do macular OCT. This is the macular OCT for this patient, showing diffusely macular thickening sparing the retinal dependent on the cilio-retinal arteries with hyperreflexia of the inner retinal layers. So from history and examination and investigation, the final diagnosis was central retinal artery occlusion with retinal artery sparing. And due to normal IOP and more than 24 hours from the start of complaint, our early management was ocular massage, and we referred him to medical specialist for more evaluation and treatment, and advised him to do regular follow-up to the ophthalmic center. Lab investigation, including CBC, random blood sugar, ESR, CRB, BT, BTT, INR, all was within normal. ECG and echocardiogram shows dilated cardiomyopathy for CAG and mild pulmonary hypertension. The cardiologist discharged this patient under antiplatelet and antihypertensive therapy, and we conducted regular follow-up for this patient. This is the last one after 6 months from the start of complaint, and we showed this improvement in vision acuity to 6/9 in right eye and 6/6 in left eye with normal IOP. So this condition is a rare condition, and the retinal artery presented in 15 to 20% of population. About epidemiology, the incidence of retinal artery occlusion approximately 1 per 100,000 per year. And in this table, we collected 4 studies related to our topic. First study results about 57 percentage representing central retinal artery occlusion, and from this percentage, about 26 showed macular sparing. The second study related to the improvement in vision. We showed about 67 rate improvement in vision within 7 days in central retinal artery occlusion with retinal artery sparing compared to 22 in non-arteritic central retinal artery occlusion without retinal artery. The third study documented the dilated cardiomyopathy is related to cardioembolism in 67% of patients. And the last study, ipsilateral carotid artery atherosclerosis is the most common cause of retinal artery occlusion with prevalence higher than 70. About etiology, many etiology, the most common etiology is embolism, maybe cholesterol, calcium, platelet fibrin, thrombosis, giant cell arteritis, collagen vascular disease, hyperregulated states, and others. Symptoms depended on the type. So common symptoms including sudden, profound, painless unilateral loss of vision, headache and scalp tenderness in giant cell arteritis, contralateral sensory or motor defects in carotid artery disease. We have 4 types from central retinal artery occlusion: arteriotic, most common cause giant cell arteritis; non-arteriotic, about 2/3 of cases, and results from local thrombosis and thromboembolism; retinal transit ischemic attack; and central retinal artery occlusion with retinal artery sparing. About management, divided into acute to restore perfusion, and subacute to prevent complication, ocular complication like neovascular glaucoma, and prevention from secondary prevention. About pharmacological, IV acetazolamide, IV mannitol, topical anti-glaucoma medication, inhalation of carbogene, sublingual isosorbide, IV methylprednisolone, IV or intra-arterial tissue plasminogen activator. About surgery, anterior chamber paracentesis, ocular massage, YAG laser, and pars plana vitrectomy, and lastly, lifestyle modification for secondary prevention. This diagram from scientific statement from American Heart Association 2022. They said when we detected the cause as arteriotic from giant cell arteritis, start by high dose intravenously methylprednisolone, and temporal artery biopsy was taken. If the cause is non-arteriotic central retinal artery occlusion, we have two options. If the patient arrived within 4 to 5 hours and no systemic contraindication, start considered IV tissue plasminogen activator. If the patient not candida for thrombolysis and below than 6 hours from the symptoms onset, considered intra-arterial tissue plasminogen activator. And as a conclusion, this emergency condition and the time will be changed the direction of management completely, and past medical history, including cardiac disease, is essential. And lastly, we have 2 home messages. This condition should be expected in cases of sudden painless decrease of vision, even there is no more effect in vision. And collaboration between ophthalmologist, cardiologist, and urologist is essential. And this is my references. And thank you very much.
Thank you, Dr. Khaled, for the really nice presentation. I enjoyed the sequence of events and I congratulate you for the early referral of the patient because this is very important. I have a couple of questions. I'll start with your history taking. You said about asking the patient about jaw claudication. Do you think your patient would be liable to have had giant cell arthritis? Is this the patient demographic for giant cell arthritis?
Maybe, and I'm asking this question to exclude some like giant cell arthritis or other
But what
difficulties.
was the patient age? 44 years, right?
44, yes, 44.
So giant cell
Uh,
arthritis is typically a disease of the elderly. It's post 60 years, or we usually see it in the 70s. Patients in 60s and 70s, not in the 40s. 40s would be very early for giant cell arthritis. So I wouldn't have focused on that point in the history taking, although it must be considered in the elderly group. So 40s is a little bit young, and we consider central artery occlusion, this ischemic insult in the young, to be a specific category. So what would you search for if central retinal artery occlusion happened in a young patient?
Yep, firstly, a young patient may be exposed to risk factors, many risk factors like hypertension, smoking, diabetes, and all these factors affected this case and maybe induced this case early.
So hypertension, diabetes, smoking, you usually see it in more towards the older age group. 40s is a little bit in between, but central artery occlusion in the young, we have to search for two causes, vasculitis and autoimmune disease, and the second
Yes,
cause
vasculitis.
is hypercoagulable state. So
Yes.
vasculitis must be excluded, and hypercoagulable states such as thrombophilia, protein C and S deficiency, factor V laden, all these must be worked up in the patient. You found dilated cardiomyopathy. It's my first time to learn about the things you said about dilated cardiomyopathy association with embolism. So this was educational for me as well. I thank you for that. Last question. What do you think the fluorescein angiography would have shown in your case?
Yes, fluorescein angiography maybe show no perfusion to the retina, and we can see the embolism. If the embolism, we can see it in some cases.
So, how would you describe the fluorescein angiography? So there's arterial phase, pre-arterial, there's arteriovenous, venous. Do you have an idea about the different phases of the fluorescein in the patient?
I think intravenously, but I don't have more information about this.
So it's the pre-arterial phase, the choroidal phase, would show fluorescence because of the cilioretinal artery. Cilioretinal is coming from
Yes,
the
yes,
choroidal circulation. So you would find fluorescence
yeah.
in the pre-arterial phase, and then in the arterial phase, there would be delay. There would be delay in the arm to retina circulation time due to central retinal artery occlusion. Yes, and that's all for me. Thank you.
Thank you very much.
Okay, thank you very much. Now, I'd like to invite Dr. Pranish to present ocular toxoplasmosis, and Professor Ibrahim Adawi will be with you.
Thank you so much, respected panelists and colleagues, and for the opportunity and for your valuable time. And I would like to present a very simple teaching case on ocular toxoplasmosis in a patient who I saw back in India. So this 35-year-old gentleman presented with the painless, blurry vision on his left eye following a fall of a foreign body on his left eye, and there was history of rubbing as well. He had a 10-day defective vision or a blurry vision, which was kind of painless and insidious in onset, gradually increased in its severity. The patient was seen in a private hospital. He was given 2 eye drops and he was given oral tablets as well. And there was no improvement in the clinical picture. So he came to our hospital. So this is an illustration which I made as a resident to show all the relevant systemic history to ask for a patient with uveitis from head till toe. And our patient did not have any of these relevant histories. There was no history of contact with pets, especially cats, relevant to our patient. But he gave an interesting history of eating undercooked meat. He was a driver, he was sleepless, he was stressed, and often he did not take care of himself in many ways. That's another important history which we could find from our patient. The examination, the right eye was uneventful, but the left eye showed a reduced vision to 4/60. Again, the right eye was normal, both the anterior and the posterior segments. But the left eye, the vision was reduced to 4/60, and the anterior segment showed circumciliary congestion here. And the patient had these medium-sized circular deposits noted on the endothelium of the cornea, suggestive of granulomatous keratic precipitates. They appeared greasy. There was this perilesional halo. There was anterior chamber reaction, around 2 to 3 plus of anterior chamber cells and flare were noted. And there were cells noted on the anterior vitreous phase as well. Corresponding the left eye fundus, the media was very hazy, showed dense vitritis. And as noted on this picture, there was an active retinochoroiditis lesion on the supranasal aspect, as we can see on this fundus photograph. And there was an adjacent retinochoroidal scar as well, which was again quite significant in our patient. And along with that, there was an exudative sheathing of the vessels noted along the arterial walls and the supratemporal quadrant, as we can see again on this fundus photograph and in this more zoomed in view. This is going to involve the arteries. They are periarterial plaques called as Chireles arterilitis. So with this picture, let's summarize. We have a 35-year-old gentleman presenting with a left eye vision loss. He was stressed out, sleep deprived, and he ate undercooked food. And he had a pan-uveitis picture involving the anterior segment with granulomatous keratic precipitates and anterior chamber reaction, with vitritis, with retinochoroiditis lesion along with an adjacent old scar with vasculitis. With these findings, we came to an anatomical diagnosis of left eye acute granulomatous panuveitis with vasculitis picture with a probable diagnosis of ocular toxoplasmosis. There are numerous differential diagnoses for our patient, from toxocara almost till the masquerade. So these white text denotes the infective causes, and these denote the non-infective or autoimmune pathologies. But the most important thing to consider is in any unilateral acute granulomatous panuveitis lesions, the first and foremost differential is viral uveitis and viral retinitis have to be considered. These two slides are going to summarize why we have considered toxoplasma and why not the others. I feel these two slides might be a good discussion points later on. So to discuss further about toxoplasmosis, the most common cause of posterior uveitis worldwide is ocular toxoplasma. It's one of the most successful pathogens, toxoplasma, which is an obligate intracellular parasite which exists in 3 primary forms: sporozoite, bradyzoite, and tachyzoite. The life cycle of toxoplasma is quite an interesting one. We have the cat being the definitive host, cattle and man being the intermediate hosts. The cat sheds feces which has the oocyst, which can be accidentally ingested by the man, by fecal-oral transmission, by handling cat litter and not by washing the vegetables properly. And the cattle grazes up these oocysts as well, and the cattle harbors the tissue cyst. And when the man is going to eat the uncooked or undercooked meat, he is going to get infected as well. So man gets infected both from the cat as well as from the cattle. So in human beings, there's going to be 2 forms of parasites. One is going to be the tissue cyst, which contains the bradyzoites. They're going to be more of a dormant form. But when there's going to be a dip in immunity or any problems going to happen for the human beings, this bradyzoite is going to erupt like a dormant volcano, releasing these more virulent tachyzoites. So these tachyzoites are going to be the much more rapidly replicating infective forms. Toxoplasma. Toxo means sickle. Gerontoxon means arcus senilis, like a bow. So these tachyzoites are going to look like a sickle. They're going to have pointed ends on both the ends. And these tachyzoites are going to be the infective forms, and they cause cell death. They cause focal necrosis along with inflammatory response. So since they're going to be running in the plasma, they are bloodborne infections. And since they are bloodborne infections, they can be congenitally transmitted via placental transmission. So congenital toxoplasmosis another crucial area to consider. The most severe infection occurs in the first trimester, but whereas, fortunately, the more risk of transmission will happen only in third trimester. And the important thing to consider is that toxo is a part of the commonly encountered intrauterine infections, the TORCH spectrum, namely toxoplasma, rubella, cytomegalovirus, HIV, herpes simplex, and syphilis. Speaking of which, the most common manifestation of congenital toxoplasma is going to be this characteristic macula involving retinochoroiditis, often leaving this cartwheel or the wagon wheel macular scar. And this wagon wheel macular scar is going to be a part of a tetrad called as Sabin's tetrad, which consists of microcephaly or hydrocephalus, mental retardation, intracranial cerebral calcifications, and along with this macular scar. But what is more common is going to be the acquired toxoplasma. So the most commonly seen presenting is going to be the acquired toxoplasma, which is not from congenital, but rather postnatally acquired. It is important to understand that toxoplasma is one of the opportunistic infections in HIV. And if we see a patient who is having ocular toxoplasma in a HIV individual, please do a neuroimaging and look for CNS toxo lesion. For example, in this patient, we can see a very large fulminant necrotizing retinitis, very large bilateral presentations. Always we should have HIV in mind. And if this patient is going to be have HIV individual, it is important to do a neuroimaging and look for these ring-enhancing lesions of CNS toxoplasma in the brain as well. And also, these patients, when they have this very fulminant retinitis, the first differential to have in mind is going to be acute retinal necrosis. But the classic feature or the most common feature of acquired toxoplasma is going to be these retinochoroiditis scars, which is going to have this adjacent active lesions, these active retinochoroiditis lesions. But less common, but most often asked in our exams is going to be this very classic presentation of headlight and fog appearance, where headlight is going to represent this solitary focal retinitis and the fog meaning this dense vitritis. Let us connect with our patient. The hypothesis is that the patient of ours has postnatally acquired this toxoplasma. It might have got by many means. Patient was eating undercooked meat for a long time. We don't know how long he has been doing that. So he has got the toxoplasma, which has got self-limited, and he could have formed a scar on his retina. And the scar in the retina is going to harbor the old intraretinal cyst. Now, what has happened recently for our patient? There was history of a foreign body, and he rubbed it. We have literature showing that when there is going to be a trivial trauma, and that can cause or activate toxoplasma by causing rupture of these cysts, the tissue cyst, which is bradyzooids. There is release of tachysooids now, and these tachysooids are going to create havoc in our patient by causing this necrotizing granulomatous inflammation involving the entire eye. So the uniqueness in our patient in this case report is that post-traumatic, which is not really usual presentation, but we could expect that. And second, hypopyon is not quite a common feature in toxoplasma. Again, our patient had a streak hypopyon. The treatment for any infectious uveitis is going to be quite political. We need to tackle the enemies, and also we should control the policemen. So both antitoxo drugs as well as corticosteroids are important for our patient. But please, we have to keep in mind that corticosteroids are strictly contraindicated in immunocompromised individuals, and they have to be used with incredible caution. We have many patients who have lost their vision by giving corticosteroids and not by giving antitoxo drugs in ocular toxoplasmosis. Speaking of the antitoxo drugs, the classic triple therapy includes the pyrimethamine and sulfadiazine, and we add corticosteroid, becomes a triple therapy. We add clindamycin to this combination, it becomes the quadruple therapy. Pyrimethamine and sulfadiazine are bone marrow toxic, so they have been replaced with safer alternatives such as trimethoprim and sulfamethoxazole. Trimethoprim and sulfamethoxazole together are called as co-trimoxazole, called by the brand name called Bactrim. So the double strength of Bactrim, which is 160 milligrams of trimethoprim, 80 milligrams of sulfamethoxazole, is given twice a day as long as the patient needs. Even after the resolution of symptoms, we need to give it prophylactically as well in immunocompromised individuals especially. The drugs being the clindamycin, azithromycin. Clindamycin is going to be a current trending drug. Intravitreal clindamycin is going to be the buzzword these days, where many ophthalmologists are preferring to give intravitreal clindamycin in patients where we have a contraindication to the routine classic therapy. So to summarize, T for toxo, we have lots of T's in here. The first T is the tachyzooids and the tissue cysts containing bradysooids. The second T is the transmission. You always be aware of the transplacental congenital transmission of toxoplasmosis. And the third T is the tetrad of Sabin in the congenital toxoplasmosis. And please understand this congenital toxo is going to be a part of another T, which is the TORCH infections, the TORCH intrauterine infections. TORCH, RC, stands for retinochoroiditis lesion, which is what we classically seen in acquired toxoplasmosis. And TORCH is going to be like this headlight in fog appearance, which we see again in toxo. Though not starting with T, arteriolitis is going to be another important thing to consider. And the final T is going to be the triple therapy, what we reserve for patients in ocular toxoplasmosis. So these are my references. Many thanks for your patience. Thank you.
Thank you very much, Pranish. Now, Professor Brahim.
Thank you, Dr. Pranish, for this fantastic presentation and your artistic drawing.
Thanks, Professor.
Some comment on the presentation, and you said in the slide of ocular examination, you comment on the abnormal head posture, right, no left. Abnormal head posture is
not relevant for our
usually not right or left. Yes, also facial asymmetry like that. Also, it is, you said it is obligatory intercellular parasite. So it is intracellular, not intercellular.
Yeah,
is
intracellular.
writing mistake, or it is obligate intracellular parasite?
Yes, yes,
okay. Usually, we see the congenital, because I'm in pediatric ophthalmology. My work, we see toxoplasmosis in congenital form more common than the acquired. Although even the congenital form, usually the intraocular or the ocular involvement usually postnatal. What do you recommend when you see a child with the strabismus, and when looking for the fundus, we see the wheel in the center, in the it is active, it is scarred form. Do you recommend to give a treatment for such patient? Because if this patient rub his eye, as you said, can refresh another cyst, or the cyst may rupture and invade another tissue. Do you recommend treatment for such case?
Not for inactive ones, Professor. I've not personally seen a child with or babies with toxoplasma, but I've seen adult patients having the macular scars or inactive lesions. So we don't usually treat inactive lesions. Only if they're activated, we treat those lesions.
Yes. Yes. Thank you. Thank you.
Thanks, Professor. Thank you so much.
Thank you very much, Pranish and Professor Brahim. Now we come to the last presenter, but not the least, of course, Dr. Tamer, and Dr. Ahmed will be with you.
My name is Tamer Mahmoud, ophthalmologist in Arab World in Yemen. My topic today under the title of Role of atropine in treatment of myopia progression among pediatric populations. So about the prevalence, how the big problem is that there is a marked increase in incidence overall, and more than 50% of all children will be myopic, with over incidence about 50% in all ages. The risk of myopic micropathy is 58%, primary opening angle glaucoma by 20%, and RD by 30%. There's many risk factors that can be likely increase the statistical indicators like COVID-19, limited time outdoors, high educational pressure, all above environmental factors are related with each other. This can be increased secretion of stress hormone and increased incidence of diabetes mellitus, which increase incidence of refractive myopia, and so the statistical finding will be increased. And as in East Asia in 2023, 80% of high school graduates are myope, 10% of this highly myopic. The childhood depression and anxiety will be related in myopic childhood incidence. The childhood depression and anxiety are involved development of ADHD, directly affected mental health like IQ, both of them reversible effects were improved after treatment of vision. But their complication like decreased IQ and deterioration of mental health development are irreversible. So we need the early detection and diagnosis and treatment of myopic patients. Okay. About the mechanism of myopia or risk factor, the myopia is autosomal dominant, autosomal recessive, or sporadic. Has three types: congenital, simple, pathologic. The last one is combined with degenerative changes. There's environmental factors related to increased incidence of myopia, like near work, outdoor activities, living environments, school performance, socioeconomical conditions, and lifestyle. So about the medical risk factor, we have two ways: medication and multisystemic disease. All multisystemic disease sharing with the increased remodeling of connective tissue, so increase in axial link elongation in eye globe. The medication like topiramate, sulfonamide, acetazolamide, sabronolactone, and so on, causing cerebrochoroidal effusion, forward displacement of lens iris diaphragm, causing glaucoma and transient myopia. So about the main mechanism of myopia, we have 5 main mechanisms. The first one is the changes in the power of the lens due to osmotic changes like diabetes mellitus. The second is changes in lens like cataract, anterior lens to conus. The changes in lens position like mitotic, anterior lens dislocation, excessive accommodation, changes in cornea like keratoconus, contact lens corneal wear bag. It changes in axial length like connective tissue disease. Okay. Retinal of prematurity, posterior statuloma, congenital glaucoma, sacral buckle. This will be causing myopia. Pathologic myopia characterized by excessive elongation of axial length. Every 1 millimeter change equal 2.5 diameter of myopia. The high myopia start as spherical equivalent -6 or worse, corresponds to axial length 26 millimeter. This increased risk of myopic myopathy, RD, and glaucoma. Okay, let's go to talking about the treatment, the main topic of this problem. The only way treatment of high myopia is prevention. So the first option is stop increasing in axial length elongation. Early cases detection is very important with cycloplegic retinoscopy until 10 years old, and also should not delay test beyond 5 years age in positive family history. The most two effective option is corrective contact lenses and daily use of low concentration atropine eye drops at 0.01%. The general measures like decreased time of near work, decreased time of wearing glasses, and increased time of outdoor is also benefit. Okay, about the atropine, the ophthalmologist researchers about the effective of atropine and decreased myopic progression is Petrosen. Many researchers after that prepared over last decade to control the accelerated incidence in myopia overall. The most of them focus on ocular atropine administration. In 2015, the WHO advised topical atropine eye drop as first line to stop myopic progression. Many studies discussed optimal atropine concentration and agreed that low atropine eye drops concentration as 0.01, 0.05, and 0.25% are the more durable effect. The most comprehensive study, we have 3 studies, ATOM 1 and ATOM 2 and Chinese lambda study over 3 years follow-up. About ATOM 1, using in this study, 100% atropine concentration eye drops nightly in 1 year over 2 years follow-up, slowed myopic progression by 77 Reducing axial length elongation, mean axial length increase is 0.35 millimeter in control versus non-control group. Okay, over 5 years, atropine 0.01 per 100%. Eye drops were more effective in slowing myopic progression with less visual side effects compared with higher doses of atropine. The atropine 0.01 100% causes the minimal pupil dilatation, minimal loss of accommodation, minimal near visual loss compared with higher dose. Children on atropine 0.01 100% did not need progressive additional lenses. Atropine at the same concentration has no clinically significant visual side effect, so balanced clinically significant 50% reduction in myopic progression. Increasing daylight exposure and reducing intense period of near work may help. And about lung study, in the Chinese population, the 0.05% atropine remained the optimal concentration over 3 years in Chinese children, with difference in rebound effect were clinically small across all study atropine concentration. The stomach treatment in this patient or this population at an older age and lower concentration are associated with smaller rebound. Okay, what is about the mechanism of atropine and decreased myopic progression? The exact mechanism is not known, but it may be take its action by blocks muscarinic receptors. Non-selectively muscarinic receptors are found in ciliary muscle, retina, and sclera. And about affection of amacrine cell in the retina, decrease the signaling of remodeling on the tissue of sclera and eye globe overall. So, how we can prepare the atropine on this concentration to use? We have 3 formula. The first one is based on normal saline. Second one is based on oxychloro complex, and the last one is based on lubricant. The first one is by adding 5 ml of atropine sulfate injection at concentration 0.6 milligram per ml with 25 ml of normal saline to make a total volume 30 ml, then divided into 215 ml bottles. The lubricant-based 0.01 100% atropine eye drops was prepared using 2.5 ml of atropine sulfate injection at the same concentration with 12.5 ml of oxychloro complex containing commercial lubricant drops to make total volume of 15 ml. The last one is lubricant-based by taking 0.1 ml of 100% atropine eye drop with 10 ml of lubricant eye drops. Okay. How we can benefit the initial assessment of the atropine? The atropine needs at least 6 months of daily use to take its anti-myopic effect and continue their effect over 1 year. Optimal effect and need continuous treatment at least 2 years for significantly decreased rebound. But in the United States, ophthalmologists continue using it until 15 years old or until 18 years old without serious side effect. You need follow up your patient every 6 months. The slow myopic progression noted in 30 to 50 patients with totally arrested in others. If myopic continues to progress more than or equal 0.5 diopter in children after 6 months, it indicates current treatment dosing probably not adequate. Okay, how we can follow up the patient after initiate atropine treatment? Firstly, we initiate atropine treatment and check up the refraction every 6 months. We have 2 ways. The first one is stable, and the second way is progressor. If there is a stable, this means the progressor is less than 0.5 diopter per year. Okay, will a continuous treatment over 2 years and stop in 1 year. After 1 year stop, maybe patient is stable. If the patient is rebound, progress more than or equal 0.5 diopter per year, restart 0.01 100% atropine concentration and encourage more time outdoor. Then continuous treatment to end adolescent or stopping or tapering. If there is a progression after 6 months of follow-up for initiation atropine, we have 3 ways. If the concentration 0.01 100% atropine and encourage more time outdoor for 2 years, or stepwise increase concentration 0.05% atropine, or other treatment as orthokeratology. So my home message is atropine at concentration 0.0100% is the treatment of choice for myopic control. It has favorable risk factor ratio. Any subject who is progressing by more than 0.5 diameter per year or more may be offered myopic control. Lower cutoff can be justified in children with strong family history of myopic progression, especially with early onset. This is my references, and thank you.
Yeah, thank you very much. And now, Dr. Ahmed, please.
Thank you, Dr. Tamer, for this nice presentation. It's always nice to talk about myopia. I think this is the most important issue now for research in the pediatric ophthalmology nowadays. I just have a few questions for you. The main issue with your presentation that I felt that is a bit outdated. I mean, nowadays, we do not recommend at all using atropine 0.01%. I'm sure we are aware of the last study that was published by the Diabetic group in 2023, and they found that 0.01% has no value at all in preventing myopia progression, and that it was equally effective to placebo, and they recommended that we should not use 0.01%. And this was the same conclusion by the LAMP study. They did not recommend using 0.01% at all. They stopped using 0.01%, so there is no rule for using 0.01% at all. We start with 0.05%. Okay, so I think you need to update your presentation a bit. Now, do you have any other options for the management of myopia, preventing myopic progression other than atropine drops?
Yes, if there's we can use orthopathology by hard lenses.
Yes.
In addition to atropine.
Yes. Any other things that you can use? Something much easier than this?
Yes, lifestyle modification like increase time outdoor, decrease near work, and decrease the time of wearing glass.
Yes, but how about spectacles? If there's any type of spectacles that you can use to reduce myopic progression? Any special type of spectacles specially designed for myopic progression?
Yes, there is a special tape that prevent myopic defocus from the retina. I can't remember what is the exact name.
They are called the defocus spectacles. Defocus spectacles. We have two main things, the DIMS and we have the BAL, and these are recommended for older age groups, because usually for older age groups, we don't use the atropine drops, we use the defocus spectacles. How about the contact lenses? Is there a rule for contact lenses? Other than the Ortho-K, do you have any type of contact lens? We also can use the multifocal contact lens. The multifocal contact lens.
Multifocal contact lens, yes, it's a rule in decrease myopic progression.
Yeah, this is another important issue. And one important thing that you missed in your presentation is the importance of family history. We need to take a good family history for the presence of myopia, because if the father is myope, if the mother is myope, then the risk of getting myopic progression is much higher than if the parents are not myope. So this is a very important issue when controlling and when managing a patient with myopia, a child with myopia. Thank you for the presentation. It was very nice. Thank you.
Thanks for you. Thanks.
So at the end of this session, I want to thank, of course, Dr. Youssef, Professor Ibrahim, and Professor Ahmed for their valuable time to be with us. And of course, I want to thank very much the presenters for their great efforts to do their best. And all presentations were outstanding, of course. And again, thank you, Dr. Tariq, for the follow-up that you are going to do in order to select the best. And many thanks for the audience for being with us. We hope to meet again in the near future with the third competition, inshallah. Have a nice evening for everybody, and Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam.